right?
Yes.
Yes.
And everyone is automatically muted.
Okay, okay. Well, I will go ahead, I think, and do a few introductions and kind of housekeeping stuff. We've still got, I know people joining in. So good afternoon, everybody, and welcome to our webinar today. We're very excited from our Oklahoma Breastfeeding Resource Center to have pulled together our physician speakers today to share as best we can the latest information on breastfeeding and COVID-19. And I first just want to say thanks so much to everyone that is working in some capacity, whether it's, and many of you are going to be in patient care or in some kind of community activities. So this definitely is a challenging time, and we appreciate everyone, and we hope everyone can stay safe and healthy and social distance and all that good stuff. Anyway, we have everybody except for our speakers on mute right now, and we will go through the information initially, and then certainly as you have questions, you can type those in the chat box, and we will definitely take questions at the end. And as you, towards the end of the when we're taking questions, you can also, if you want to unmute yourself, kind of raise your hand or whatever, if you want to ask or comment verbally as well. So, and we are recording, and this recording will be made available soon. Sarah can probably speak to that a little bit, but hopefully within the next day or so we'll get that recording, and the slides will also be available on our website. So without further ado, I'm going to move us along here. So our presenters today are Dr. Doug Drevitz, who has really become the face of infectious disease here at the University of Oklahoma Health Sciences Center. I'm sure many of you have seen him on many newscasts. We also have Kate Arnold, formerly of the OB-GYN department here at OU, and now the Women's Health Director at Variety Care, and Melinda Webb, who is a pediatrician at Stillwater Medical Center and is our chapter breastfeeding coordinator for the Oklahoma Academy of Pediatrics. And then myself, of course, director of our Breastfeeding Resource Center and executive director of the Oklahoma Mother's Milk Bank. So, so as we get started today, we wanted to put this webinar on. I've watched a number of other webinars from other states, other organizations, trying to look at all of the information. And really, we just wanted to be able to address what's happening that's impacting breastfeeding mothers and babies during this pandemic. And how do we do the best we can to protect the health of mother and baby, and particularly that newborn, while also, minimizing any potential impact on the breastfeeding relationship, because we know that has immense importance as well. So this is just a kind of, one list of some of the things that we're seeing and hearing both here in Oklahoma and around the country. We're hearing of immediate separation of mother and baby while test results are pending. So if the baby at birth is considered a patient under investigation, PUI, I'm sure many of you have seen that acronym already too much, they may be admitted to a NICU isolation room, limiting direct breastfeeding, no skin-to-skin contact, but promoting milk expression, or some, not allowing the mother to breastfeed if she's a PUI or positive already. Limited teaching, maybe we're trying to get moms and babies out the door faster, so not getting as much time to establish breastfeeding. And then once they get out of the hospital, what's happening with outpatient lactation consults, and a lot of that happening either by telephone, telehealth. WIC is conducting all of their, in Oklahoma, WIC is conducting all of their appointments and nutrition education and so forth by telephone only, and no home visits right now. So our wonderful health department staff, who normally are out there seeing new moms and babies in the home, such as Children First and Parents as Teachers, all of that's being conducted by telephone. So so that's kind of where we are and what we wanted to try to address today with our presenters and what's the most current information. And as everyone knows, it's changing day by day. It'll change after we finish this webinar, so more information will come out. Whoops, I had missed, sorry, I've got a slide out of order somehow. Anyway, this is what our outline will be today. Dr. Drevitz is going to talk about transmission and symptoms. Then Dr. Arnold is going to talk, really go through what are the current medical recommendations from a number of organizations. Dr. Webb is going to talk about, we're actually going to give some examples of what we know is happening in our epicenter in New York City, and then care after discharge. And I'll touch briefly on some aspects of the importance of breastfeeding, and then also donor milk. So you'll see me kind of pop in a couple of times here. So before I hand off to Dr. Drevitz, we wanted to share this quote that Lori Feldman Winter had published in an email thread with a number of physicians that we thought was a really good way to kind of kick this off today. And she said, as we struggle to develop guidance for breastfeeding during the COVID-19 outbreak, we must always consider the risk of not exclusively breastfeeding. Mother-baby separation, use of pumps and other equipment to express and feed human milk to a newborn, and other techniques to reduce both contact and droplet spread may seem reasonable as ways to reduce viral spread from the mother to her newborn. However, each of these strategies comes with a risk of supplementation or cessation of breastfeeding, which I know many in this audience know quite well. And she goes on to say, first, do no harm. Without all the evidence, and especially in times of overwhelmingly rapid spread of COVID-19, depletion of resources, including healthcare workers and spaces to care for mother and baby, we must act prudently to protect the health of the mother and her baby. This includes effective management of exclusive breastfeeding and recognizing the potential increased risk of disease in formula-fed infants. So with that, I will move on and hand over to Dr. Drevitz.
Okay, well, thank you very much, Becky, and thank you for asking me to be part of this webinar and this group of faculty. And to start out, I'd like to give a shout to my wife, who is a lactation consultant and who has been a great resource for me in learning about the importance of breastfeeding and exclusive breastfeeding. Next, and that'll bring out the next slide. So to start with, I just thought I'd bring up a little bit of background on coronaviruses and COVID-19.
What's the coronavirus?
And coronaviruses are large RNA viruses, and RNA viruses are a type of virus that's like influenza virus. And they infect humans and other animals, and we acquired them from other animals. And in fact, this particular strain evolved within bats. Next slide, next, could you tap it?
Yes, got it.
Tap. And so they cause a variety of diseases in humans, and they have a big range of severity. And there are 4 different coronaviruses that circulate every year in the United States and other countries, and we call those seasonal coronaviruses, and they cause the common cold. Coronaviruses can also cause a number of severe illnesses, and the first one that came about was called SARS, and that stood for Severe Acute Respiratory Syndrome. That was identified in 2002, also in China, and it caused 774 deaths, and with a case fatality rate just under 10%. Tap this button, please. The next one to coronavirus to come about that was bad in humans was called MERS, and that stands for Middle East Respiratory Syndrome. This was identified in 2012. And
sorry, caused a lot of background. Sarah, can you just double check that everyone is muted?
Yes, I can. I'm going to mute all, and then if our Dr. Drevitz can unmute himself after I do,
okay,
just to make sure. Okay. Muting all now.
Okay, I should be unmuted. And Becky, could you give me a thumbs up if you can hear me?
We can hear you.
Okay, great. So the next coronavirus to come about was MERS, and that is focused in the Middle East. About 90% of the cases are in Saudi Arabia, And as of earlier this year, it had caused 866 deaths and has a very high case fatality rate. And then COVID-19 is the most recent coronavirus to evolve. And that was identified in late 2019 in December. And so far has caused almost 1.5 million infections worldwide, with case fatality rate somewhere around 2% of identified cases. Next slide, please. So how do we get this, or how does it spread? And so this is a diagram of how most respiratory viruses, including COVID-19, are spread. To start with, in the middle of the picture, you have an infected individual, and they cough or sneeze. And when you do that, you produce a variety of droplets out of your mouth of different sizes. Small ones, which are called the droplet nuclei on top, will stay in the air longer and travel further. The larger droplets travel about 1 to 2 meters and then settle out of the air. And then if you have never seen this infection before and are susceptible to it, then you can get this either by inhaling the droplets or the droplet nuclei. You can get them through direct contact. If somebody coughs or sneezes on their hands and then handles a doorknob, and then you come right behind them and handle the same doorknob and then touch your eye, that's called the direct contact. And there's also indirect contact if it goes on an inanimate object for a while and you pick it up from there. So there are a variety of ways that you can get infected, and this is why we wear masks and constantly wash our hands. Could you advance, please?
Yes.
There are special circumstances also about transmission of viruses, and that's particularly pertinent to what we're talking about now. And this is if the individual is pregnant or breastfeeding, then there's also a possibility of mother-to-baby transmission. And this happens by different ways. One way is what's called vertical transmission, and that's either through blood or through the placental infection, or infection as the baby passes through the birth canal. Next, please. But there's also the potential for transmission for breast milk. Next slide, please. So what do we know about how the virus is transmitted? Well, the good news is that there's very scant evidence for vertical transmission. There are 2 reviews out of China that are there cited that show there's no evidence for intrauterine infection and no evidence for transplacental infection from pregnant women to their fetuses. And then there's just a recently published report out of New York City that looked at 18 infants born to mothers and found also that there is no evidence of viral infection when they did nasopharyngeal swabs of the babies postpartum. And all of these infants were discharged to home. Next slide, please. So in terms of breastfeeding, it's also considered to be safe to breastfeed. There are studies showing that there is no evidence of this virus, the SARS-CoV-2 virus, that is passed from, in the breast milk. And in fact, pasteurization will very nicely kill this virus. So pasteurized donor human milk is considered sterile and free of viruses, including this virus, and is very unlikely to be spread directly within breast milk. Next slide, please. So how often are children infected? And you've all heard about large numbers of infections, and what is very clear from data from Asia, Western Europe, and the United States is that children having serious infections is quite uncommon compared to infection rates in adults. There's a study in Korea that showed that less than 1% of all cases that they identified were in children less than 9 years old, the youngest of which was just a couple of months old. Similarly, there was a study in China that found only 9 infants hospitalized with COVID-19. At the same time, there were about 31,000 cases in the country or in that area. And none of these infants required intensive care or had severe complications. Next, please. And most recently, there was a study published by the US Centers for Disease Control that came out just recently. And they looked at almost 150,000 cases of COVID-19 reported in the United States up through April 2nd. They found that just under 2% of all of these infections occurred in patients less than 18 years old. And what's notable is that this same age group, this demographic, accounts for 22% of the US population. So although they comprise nearly 1/5 of the population, they comprised that only 1/10 of those were being infected, suggesting they're just not a high infection rate. Of those pediatric cases, infants under 1 year of age, though, accounted for 15% of them. So infants less than 1 year of age are considered more at risk than our other pediatric patients, but they are still greatly underrepresented when they're compared to the entire US population of that age. Next slide, please. So when the Centers for Disease Control looked a little bit closer at these individuals, they found that of the 2,500 children who were infected with COVID-19, only 5.5% roughly were hospitalized, and 1/10 of those were admitted to an intensive care unit. And compared with adults in the 18 to 64 age group, that hospitalization rate is probably about 1/5 as many were hospitalized. And again, just a fraction of those were admitted to the intensive care unit. So roughly 0.6% of children were admitted to the intensive care unit, or on the order of 2 to 7 times as many adults were admitted to the intensive care unit. Next, please. And similarly, when you look even more carefully at children aged less than 1 year old, these in fact are the highest percentage of hospitalized pediatric patients. And what they found is that 62% of all children aged less than a year were hospitalized, and 5 of those included those who were admitted to the ICU. Next, please. So what do symptoms look like in the pediatric population? And by note of disclaimer, I am not a pediatrician. I am an adult infectious disease physician. But this is what the literature says. So you look at a constellation of symptoms, and what we know in adults is that no single symptom is sufficient to identify COVID-19. And in fact, you have to look at a constellation of symptoms. So at the top, you see that the triad of fever, cough, or shortness of breath, one of those 3, were present in almost 3/4 of all pediatric patients and over 90% of all adult patients. So these 3 signs independently, if you have one of them, are still the most accurate in terms of diagnosis. Independently, fever was present in just about half of pediatric patients, as was cough. Shortness of breath was quite a bit less frequent, being found only in 13% of individuals. Other reported symptoms in pediatric patients were headache, sore throat, and myalgia, but notably, they were also about half as frequent as those same symptoms were in adults. Diarrhea is not common, but is found. Similarly, nausea and vomiting, ruddy nose, and abdominal pain are much less frequent, but can be found as well. Next, please. And also, what you find in children, as also in adults, is the presence of underlying medical conditions in individuals who have more serious infection with COVID-19. Of the children who were hospitalized, they found that 23% of them had at least one underlying medical condition. Of those, the most common was some form of chronic lung disease, which included asthma, which is present in about half of individuals. Cardiovascular disease was present in just over 1/4 of individuals, and some kind of immunosuppressed state was present in 1 out of 8. Next, please. Of the 77, and notably 77% of hospitalized children had at least one or more underlying condition. And I should say, this is also what we see in the adult population. It's the power of the underlying medical conditions that really are what's bringing people into the hospital. Next, please. And lastly, I should say that there were 3 deaths of the pediatric patients that have been reported. But notably, the CDC states that these folks or individuals are still under review to confirm that COVID-19 was the cause or a likely cause of their death, because it's not clear. Next, please.
All right, let's see, Sarah, or I'm not muted, right? So thank you, Dr. Drevitz.
Pleasure.
So I'm just going to briefly talk about the importance of breastfeeding on infant health. And I know pretty much everybody in this audience, we could go through the list of all the benefits of breastfeeding, the health impact for the mother and the baby. So we know that, but I think this is a good time to remind us of the power of breastfeeding in human milk for programming the baby's immune system. And that really the human milk microbiome has so many bioactive factors that really shape the baby's microbiome, and that's what helps contribute to the short and long-term impact on their health. And so any kind of exposure during that critical window of breastfeeding initiation, such as no direct feeding at the breast, or temporary separation or whatever, that can alter that baby's that infant's immune programming. And you have many active immune components in human milk. You have immune factors, proteins, peptides, fatty acids, oligosaccharides, and then a wide variety of microbes that are all present in human milk that contribute to that human milk microbiome and the immune activity that's happening. And so this was just pulling a couple of, I thought, a few important quotes from these two publications. One was early colostrum and exclusive breastfeeding establish an optimal and an intact immune system, and those protective proteins that are so abundant in human milk and promote development of the baby's immune system. And this came from Lori Feldman Winter's publication and her team of authors just recently. Early introduction of supplemental formula is associated with a greater than 2-fold increase in risk of early cessation of breastfeeding, even when controlling for confounding variables. And there are substantial differences in the composition of the gut microbiome in preterm infants fed formula versus mother's own milk or donor human milk. So how do we protect that baby, the baby's immune system, the gut microbiome, and also, of course, avoid maybe serious infection with COVID-19. So when we kind of turn our spotlight on pasteurized donor human milk, and many people say, oh, donor milk is great, but it's nowhere near as good as own mother's milk, and once you pasteurize it, it loses all of the immune protection in human milk, and that is just absolutely not true. It is true that it's not as powerful as own mother's milk that hasn't been processed to some degree, but we still have a lot of immunological factors that are active in pasteurized donor milk. Yes, we do pretty much lose lactoferrin and enzymes and some growth factors, but most of secretory immunoglobulin A remains, and we have many components that there's no change in, particularly the oligosaccharides, which this fun little graphic here just kind of gives you a picture of the importance of those human milk oligosaccharides in protecting the baby's microbiome as well. So pasteurized donor milk certainly plays an important role as well in protecting the immune system. And I thought this was really, this was some kind of new information as well, that the bacteria that's present in fresh human milk or unpasteurized human milk really plays an important role, that probiotic effect on the baby's immune system and stimulating the immune system. And while pasteurized donor milk is, yes, a sterile substance, and we've, through pasteurizing, destroyed any bacteria and viruses, the components are still there. And so there's also some thought that pasteurized donor milk harbors this kind of ghost microbiota or paraprobiotics, and so still has the ability to stimulate the baby's immune system. So even if we're using donor milk because we don't have enough own mother's milk. So anyway, so that was just kind of a quick picture of that, and I'm getting ready to turn over to Dr. Arnold, who is going to go through some of the recommendations from, this is the list of the different organizations that we've collected current recommendations around breastfeeding and COVID-19. So Dr. Arnold, are you ready to take off?
Yes, ma'am.
All right, so I'm going to move on, and you just tell me when to go.
Okay, So I want to thank Becky again for putting this together. I know as I'm still seeing patients in clinic, there's a lot of uncertainty, especially for women who are pregnant right now, about what delivery is going to be like and what breastfeeding is going to be like. So I think this is a great platform, and I'm happy to stick around and answer some questions at the end. Becky put this together. This is an amazing list of all of the recommendations from different organizations. So we'll go through each of these, and then we'll end on ACOG, which is my organization, the OBGYN organization. So starting out with the World Health Organization. World Health Organization says that infants born to mothers with suspected, probable, or confirmed COVID infection should be fed according to standard infant feeding guidelines. So they recommend taking all of the precautions that Dr. Drevitz just reviewed, as far as hand washing, and then making sure that we're disinfecting all the surfaces. And so that's the World Health Organization's recommendations. Next. They also recommend that mothers and infants should remain together, practicing skin-to-skin contact, that they can room in, whether or not anyone is suspected or confirmed to be COVID-19 virus infection. I will say with the World Health Organization, they, as their name, are covering everywhere, and so they tend to give recommendations that take into account all kinds of different socioeconomic situations, as well as access to medical care. So they're always going to be a little more focused on breast milk. Next. The Italian Society of Neonatology and Union of European Neonatal and Perinatal Societies, what a mouthful, said that if a mother is previously identified as COVID-19 positive or is a person under investigation, but is asymptomatic or not very symptomatic, then rooming in is feasible and you can do breastfeeding. If, however, the mom is too sick to care for the newborn, then obviously they can have extra help. Next. As far as the Academy of Breastfeeding Medicine, they emphasize that the choice to breastfeed in the hospital is the mothers and the families. And I think that is so important. As healthcare professionals, we can give our recommendations, but ultimately this choice is going to come down to a personal one between your family. So if the mother is well and has only been exposed, or is a person under investigation with mild symptoms, then breastfeeding is a reasonable choice. You want to do your best to prevent any transmission using a mask, gown, and careful hand washing. If the mother has COVID, then there's going to be more concern. However, you can still choose to breastfeed and provide express milk for the infant. I think Dr. Drevitz brought up a really good point, which is that our concern is not so much for vertical transmission, like he mentioned, so transmission during pregnancy or labor. It's not so much for transmission in the breast milk. It's the transmission that can happen when you're caring for the baby, and all the respiratory droplets that we worry about. Next. There are several choices that hospitals and patients have in terms of housing for a breastfeeding mother and her infant. Generally, we support rooming in, and that means that the mom and the baby are in the same room. If that is the case when I assume they're talking about when a mom is under investigation or is positive for COVID.
Yes.
Yes. The bassinet can be kept 6 feet away from the mom's bed. As we all know, that's the social distancing distance. And then we want to take precautions to avoid spreading the virus. So again, washing your hands, wearing a face mask for any contact with the infant. And then if we do need temporary separation, that would primarily be because the mom is too sick and needs medical care for herself. Next. This is from Breastfeeding Medicine from the journal. And so they said, given the reality that mothers infected with coronavirus have probably already colonized their nursing infant, continued breastfeeding has the potential of transmitting protective maternal antibodies to the infant via breast milk. Thus, breastfeeding should be continued with the mother carefully practicing hand washing and wearing a mask while nursing to minimize additional viral exposure. So that's addressing moms who are already breastfeeding. You have no reason to stop breastfeeding, okay? Just continue with your precautions. Next. The CDC, so this is going to be the United States recommendations. I'm sure you all have heard all of this on the news in terms of following the CDC recommendations. As far as inpatient obstetric healthcare settings, transmission after birth by the respiratory secretions is again our concern. And so to decrease that risk, they recommend considering temporary separation. Becky bolded that. I 100% agree with that. This is just a consideration. They would have said strong recommendation if that's what they meant. I'm sure they chose their wording very, very carefully. And you want to think about the risks and benefits of temporary separation of the mother from her baby in coordination with the mom. So again, highlighting that this is a family decision, okay? Next page.
And Dr. Arnold, I'll clarify too that the bolding is actually the CDC's.
Oh, excellent.
I would love to claim it, but and so all of the CDC, text here was bolded based on what they had on their website.
They say that if rooming in is done, then it can be in accordance with the mother's wishes, or sometimes it can be unavoidable due to facility limitations. In all of these cases, we still want to be using all those precautions that we keep harping on to make sure that we're keeping that baby safe. So if you're a person on investigation, if you think you have COVID, then 6 feet away from the ill mom. Next page. More recommendations from them. If we do breastfeeding, then you want to wear a face mask and practice hand hygiene before each feeding, again, because that's how it's going to be spread. During temporary separation, if you want to breastfeed, you should still be allowed to pump and express your milk, okay? After each pumping session, we definitely want to clean all of those breast parts thoroughly, including the whole pump, any tubing, and then the expressed breast milk can be fed to the newborn. This, again, with Dr. Drevitz, it's not the breast milk that we're scared of, all the intimate contact that happens with breastfeeding, okay? So the expressed breast milk is fine. There's no need to pump and dump. Next page. And then this was an email response saying from the Kriya, I don't know how you say her name, Kriya Parin. Thank you. She said, we have heard similar concerns from other partners about how the CDC's interim guidance is being interpreted. The guidance considers the risk of transmission of the virus that causes COVID-19 from a mother to her newborn, including, and again stressed, consideration of temporary separation. However, we do not recommend the routine separation. The risks and benefits of temporary separation of the mother from her baby should be discussed with the mother by the healthcare team. The CDC is working on interim guidance to clarify this. Next page. Mother-to-child transmission of coronavirus during pregnancy is unlikely, but after birth, they are susceptible to that person-to-person spread. That's again clarifying that vertical transmission risk that Dr. Drevitz stressed versus the post-birth droplet concern. A very small number of babies have tested positive for the virus shortly after birth. However, we don't know how they acquired that virus. And the virus has not been detected in amniotic fluid, breast milk, or other maternal samples.
And so if I can interject just briefly, so just to clarify, the first kind of set of recommendations were for providers. So that's on the CDC's website as far as interim guidance for providers in the healthcare setting. And now this next set of recommendations are really kind of for the public and for, for families and so forth. And that was just published over the weekend where they made some changes in that. So.
They stress that breast milk does provide protection against many illnesses and is the best source of nutrition for most infants. Patients and their families can decide whether and how to start and continue breastfeeding. In limited studies, again, COVID-19 has not been detected in breast milk. If you are sick and choose to direct breastfeed, you just want to wear a face mask and wash your hands before each feeding. Next page. If you are sick and choose to express breast milk, you can do that. You want to have a dedicated breast pump, wash your hands before touching any pump or bottle parts and before expressing breast milk. You want to clean the pump thoroughly, as we talked about. And then if possible, to decrease that risk of transmission, you can have somebody who as well feed the pumped milk to the infant. Next page. This is ACOG, so this is our American College of Obstetricians and Gynecologists, and they say that there are rare exceptions when breastfeeding or feeding expressed breast milk is not recommended. Whether and how to start or continue breastfeeding should be determined by the mother in coordination with the family and the healthcare team. Currently, the primary concern is not if it can be transmitted through breast milk, but rather an infected mother can transmit the virus through respiratory droplets. Next page.
All right, so then I think we'll hand over to Dr. Webb.
Becky, can I add one more thing in?
Sure, absolutely. Do I need to go back?
No, you're fine. One more thing that I'm happy to take questions about, but just as an OBGYN, I would stress that in coordination with most of the hospitals in the area, all these hospitals are taking so many precautions to protect you from COVID as a pregnant patient if you are worried about delivering soon. We are hearing a lot about home births in Oklahoma. I would encourage people to still deliver in the hospital. It's still what all the professional societies recommend. And just know that there are more meetings than you can even imagine going on about how to keep you safe during your delivery. So, and I'm happy to answer any questions about that.
Good point. I'm sure we will have some at the end there. So, Dr. Webb, are you ready to take over?
I'm ready to take over. Unfortunately, I'm the pediatrician. I get to present the Academy of Pediatrics recommendations. A little more strict than everybody else's, as you can see. So this was over the weekend as well, or last week, these recommendations came out. The big question is, can mothers and well newborns room in? So while difficult, they are recommending temporary separation. And this would be for positive moms, although it doesn't actually say that on the question and answers. Instead of consider, it says ideally admit the infant to an area separate from unaffected infants. Use gown, gloves, eye protection, goggles, and standard procedural masks for the care of well newborns. Then that's acknowledged to be challenging and almost impossible, given the crunch where many of our rooms are taken over for other patients. If she does choose to room in despite these recommendations, then the infant should remain 6 feet away and use some physical barriers as needed. So that's our recommendation. Some things about that question, if you want to move to the next. Again, it's not very practical if you have a large delivery service. You've also got nearly everybody is a person of interest or under investigation. If you're doing 2 patients, that's twice the PPE, 2 different rooms, much more risk of exposure. And then also breastfeeding is not going to get off to a good start. Next. Can the baby breastfeed? Again, they reiterate that we haven't found it in breast milk, that they may express their breast milk by using appropriate breast and hand hygiene, and then it has to be fed to the infant by uninfected caregivers. If she does request direct breastfeeding, she has to comply with strict preventative precautions. Next. So, some things to consider about that. Again, there's nothing that suggests that we have increased transmission or illness in newborns versus directly breastfeeding. So there's nothing that says directly breastfeeding is going to be a greater risk than giving express breast milk. And it makes it sound a little bit like the only way you can breastfeed directly is if you're going against the AAP or the against medical advice. Then if you are pumping, people are handling your breast milk from one room to the other. There's a lot, there again is the people involved. And once again, if we interrupt breastfeeding or we can't allow these moms to practice, then they're very likely to never breastfeed once they go home. We know that not breastfeeding then increases the risk of illness in the infant. Next. Some other things about just separation that we have to think about in general, as well as the effect on breastfeeding. It can disrupt lactation, therefore leaving mothers frustrated and more likely to quit. There can be an increased risk of maternal and infant readmissions, particularly bilirubin or increased weight loss. If we send her home without breastfeeding well, becomes more risky. We may not have the space or the supplies. We may be putting healthy babies in NICU beds to separate them, which then creates a whole other problem. Just not being around your baby, or your baby not being with your mother, can cause psychological trauma and attachment disorders for both mom and baby. And then we've already seen that some of our minorities are having more impact from COVID, so this may create greater consequences for those. Next. Also, if they haven't been allowed to initiate direct breastfeeding, then again, they'll quit once they go home. Right now, there's not a lot of support active out there. WIC is telephone only. We also are seeing more demand for WIC because there's job losses, so only telephone, fewer people to provide those telephone calls. Also, we saw people stockpiling formula, and many of our moms were worried about formula not being in large amounts. Just like toilet paper, people that didn't even have babies were stocking up on formula because you could drink that if there was a shortage of milk, even as an adult. Again, food and formula insecurity is an issue. I think what bothers me sometimes is that we spend all this time talking about breastfeeding and harms of breastfeeding or harms of being with your baby, and we really don't emphasize formula preparation. We don't tell people how to do that correctly, and there's a huge amount that's involved in that. And just like Dr. Arnold said, if you have to separate and people know they're going to get separated, they are more likely to attempt a home birth. Next. So again, how do you support them? Again, you have to weigh the risk of the newborns getting severe COVID infection, which is rare but likely finite, with the risk of undermining the establishment of breastfeeding and the consequences of breastfeeding failure, which can be significant, particularly in low-income settings. Failure to establish breastfeeding could put the newborn at risk of food insecurity and other infections. And if they're not going to breastfeed, then separation may make more sense if other factors allow and if it seems important. And this was just a trend that Harvard put out. Next. So we looked into what are the big centers that are having the biggest impact, what's happening with them. Many of you may know Elmhurst Hospital. That was probably the hardest hit hospital in Brooklyn. So since March the 30th, they've been screening every mother. So really every mother that comes into their hospital to deliver, and then their infant is a person under investigation. If the infants don't require NICU care, they are isolated with their mothers, so they're kept with their mothers. They breastfeed with a mask and hand washing. They both get good PPE. Every delivery has adequate PPE. Then they have been discharging their mothers early at 24 hours for vaginal deliveries and 48 hours for C-sections. Now that's our standard discharge protocol here, but they've considered that early. Some places I know are pushing that even further. If they're a healthy newborn, low risk, they're trying to get them out. One reason they're keeping them for 24 hours, which we'll see in the next slide, Becky. I'm sorry, I'll come back to that one in one of our slides. The moms aren't allowed any visitors, both during labor and delivery and postpartum, and they only have one designated visitor in the NICU. He also says that many mothers are positive where the infants are negative. They breastfeed after discharge with masks and hand washing. If the mother or relative is healthy, they can take care of the infant without a mask, but they are following the CDC guidelines of basically wearing a mask and hand hygiene for 3 days without symptoms and 7 days from the onset of symptoms before you end the mask and the hygiene. Next. This was from New York Presbyterian Hospital, the Columbia University Medical Center. They have 25,000 deliveries a year system-wide. They also test all the mothers. Again, this is New York City. To date, when they've tested, about 50% are positive, and then only 30% are symptomatic, or only 70% are symptomatic, 30% are asymptomatic. They keep mothers and babies together. They continue rooming in. They test the babies at 24 hours of life. They found that if they did that earlier, it was not a reliable test. They also send them home early, usually right at 24 hours. Then they have a special clinic for those COVID positive moms, their babies. They get an in-person follow-up in the first week. They do not see a lot of positives among their newborns, despite having those large numbers of positive moms. So that's also very good to know. So what do you do? How do you manage that? What do you do to keep breastfeeding going? If they're routinely separating their mother and baby, then mom has to do early and frequent milk expression. She can do hand expression for the first 2 or 3 days. That would also minimize pump use. So mom should be taught how to do that. Again, good hand hygiene. If you have pasteurized donor milk, which we can get, use that as a bridge until moms can initiate. They need to be referred for lactation support, however we can do that. We need to give her those guidelines as to when she can initiate direct breastfeeding if we've separated. And then we need to be sure we're teaching proper hand hygiene and bottle preparation for every mom, whether they're formula or breastfeeding or pumping and giving. Next. These are for what do you do, not only when you're sending them home, but also if you have a mom that's already breastfeeding, well-established breastfeeding, and she becomes COVID positive. You need to keep her breastfeeding. She should use masks, gloves, or hand hygiene. Again, same thing. If you're going to be close to your baby, you need to be protecting yourself. Use other family members if available. But remember, if mom's positive, everybody else in the house is likely to be exposed and may also develop symptoms. So really, they should probably be also masking, wearing gloves, and using good hand hygiene. You should restrict visitors. Once she's fever-free for 72 hours and 7 days past the initial onset, then she can discontinue her mask, but she should still continue good hygiene, hand hygiene. If you send them home early, you need to have early follow-up. Really, this is across the board, not just for lactation support, but we're also looking for weight loss. We're looking for jaundice. Most practices are still seeing patients in person if they're less than 6 months of age. We're seeing everybody less than 2 years to be sure that they get their shots, and even up to 4 years for well child checks. So we've worked out a way to see our patients in the office and minimize exposure. Next. Again, most home visiting services are not going to the homes. The health department doesn't have this. There are some private IBCLCs who are doing some home visits. The breastfeeding support groups may be meeting, but virtually, so you need to look into that. And then we still have the breastfeeding hotline available 24/7 by phone or texting.
All right, so thank you for that, Dr. Webb. So just a few more slides here to kind of wrap up some of the information that we wanted to cover today. And just to reiterate the safety of donor milk from our nonprofit milk banks around the country. We have, many safeguards in place that we always do, so that has not changed. And just for some of you who may not be aware of all the processes, our donors are rigorously screened for medical and lifestyle risk factors. They have their blood drawn and tested for HIV, HTLV, Hep B and C, and syphilis. Then, once they're approved as a donor and we are taking that raw milk in, that's pasteurized by the Holder pasteurization process that we know kills HIV, CMV, other viruses and bacteria. And then, of course, no milk is dispensed until cultures come back negative for bacterial growth. So pasteurized donor milk is a, quote, sterile product. And as Dr. Drevitz mentioned earlier too, we've had studies from the previous outbreaks of SARS and MERS to show that heat inactivation absolutely destroys those viruses. And then just once again came out last week in Lancet Microbe, a quick little publication showing that heat treatment of the virus, this wasn't in milk specifically, but that heat treatment to 56 degrees for 30 minutes or 70 degrees for 10 minutes completely inactivated this specific SARS-CoV-2 virus. And so that was really good news, though Habana is working on getting some actual studies done looking at human milk that is spiked with the virus and going through our Holder pasteurization. But Holder pasteurization heats the milk to 62.5 degrees for 30 minutes. So we're well within what this study has shown as well. So that was very exciting to see that come out. So just, reminders too that our milk banks still need milk donations. We still have babies being born. We still have preterm and critically ill babies in need of safe pasteurized donor milk. And we may, as with separation on some mother baby units, we may see, of course, even more need in some of those specific types of situations. So, and our milk banks all over the country work together. So it's really a network, and any rumors you hear of milk banks starting to ration milk and we don't have enough or what have you, that is not true at all. And sometimes there might be a milk bank that's had a greater demand in a hot spot of the country, and other milk banks, of course, will, they put out a call and we help supply milk. So we always make sure that we can meet the needs out there. And so I just wanted to share a couple of notices that our own Oklahoma Mother's Milk Bank sent out recently, so you kind of know, or if you get questions about this. But so this went out to all of our donors, that if you've really had close contact with someone diagnosed or suspected of having COVID-19, then there's a 28-day deferral period. So we wouldn't want you to be donating milk during that 28-day deferral period. And this would also apply to healthcare workers who maybe have been taking care of COVID-19 patients, because we certainly have a lot of people in the healthcare profession who are breastfeeding moms and end up becoming wonderful milk donors as well. So just kind of putting that really extra safety net around the milk in those cases. And then if the donor mother herself has been diagnosed or is being tested for COVID-19, then definitely call our milk bank and report that. And then our milk bank team will work with that mother on identifying kind of the safe zone when she can start donating again. But we will actually defer her for 7 days prior to symptoms and for 21 days after her diagnosis. And now, of course, we have concerns of safety of not only our milk bank staff, but our donor moms. And so we also let them know that you don't need to be afraid of donating your milk or dropping your milk off. We're trying to minimize your exposure and our team's exposure and our the staff at our various depots around the state. So we have certainly arranged for any mom to drop off her milk and she doesn't have to get out of her car, call the facility where she's normally, dropping off milk, and someone, will meet her and just take the milk directly from her car. And our staff at our main milk bank location here in Oklahoma City. We'll meet moms downstairs, and once again, she doesn't have to exit the vehicle. So just reassuring moms that we're trying to make this as easy as possible. So and actually, let me go now. Let me not screw up now. So if I can go back, we've actually, you know, seen an increase in moms wanting to donate. So that's just speaks once again to our Oklahoma standard, and that people really step up in a crisis time. So that's been really great to see. And one of the challenges I think we see too is just with maybe some of the clinics having reduced hours or doing, you know, some telehealth or remote work. It's a little slow sometimes getting the signed forms back from physicians so that we can improve those donor moms. But generally we're doing really well, well stocked, and with those supplies. So to wrap up here and then turn over to kind of our Q&A time, just some reminders, and once again, these slides will be available as well, but our Oklahoma Breastfeeding Hotline, 24/7 access to IBCLCs, and moms can call or text OK2BF to 61222 and get hold of a lactation consultant. And we are ready for increased volume. So we've kind of ramped up. So with some other resources not being available, we're hopeful or we're ready for increased calls and contacts, and ready to help. And then just, you know, our Oklahoma AAP now has kind of a breastfeeding section on their website. And then our Breastfeeding Resource Center has, where Jacqueline's working to update our statewide list of lactation support, so we know what's going on, who's doing in-person or certain limitations, or who's doing telehealth, you know, any kind of home visits and so forth, what's going on around our state. And then Amanda is our provider in our OU Physicians Lactation Clinic, and we are still doing some in-person and then also telehealth consults there as well. We have some sample policies about handling express breast milk, particularly for babies in the NICU, that we've been trying to gather. And then coming soon, Jacqueline's been working hard on a prenatal breastfeeding education module, which has been on our radar for some time, but this really kind of pushed it up in priority, since so many breastfeeding classes and WIC support, you know, are less available. So stay tuned. You'll hear from us hopefully within the next week or so that those are ready to go, and those will be free resources for any of your patients or clients. Just some others that you can check later on, where we know of some webinars that have been out there, or the ABM podcast was really good. It's long, but the first hour is on hospital issues, and the second hour is on kind of outpatient or babies in the community, breastfeeding issues in the community. So some other resources there. So you can see all the references that we used, and we can go back to the faces of all of our presenters, and I guess we will open it up now for questions. So Sarah, I'm wondering, do I need to try to check in?
I have been monitoring the chat box. We have not received any questions yet. Just asking if the slides and the recording would be available, which they are going to be.
Yes, those are available. So do we have any, any questions for any of our presenters today?
Actually, Barbara O'Brien says she has a couple of statements she would like to make. So Barbara O'Brien wants to unmute herself.
Can she unmute herself then?
Yes, I think I just did. Can y'all hear me?
Yeah. I
just wanted to make a couple of statements. One of the slides previously had an infant wearing a mask, and Sarah Johnson, our new patient, who's on our staff now, said she has noticed a lot of questions on different web platforms from parents and asking whether they should put masks on their infants. So looking at the CDC recommendation, it does not recommend, they do not recommend placing masks on children under 2 years of age. Right. So that's a good thing to note if you are educating your parents as they leave. The other one was about Elmhurst in New York. I know that previously there were some that were limiting visitors in the labor and delivery units where women could have no outside visitors. And
right. And that's changed.
yes, that's been changed. The governor issued a proclamation or whatever, an executive order that every woman is allowed to have at least one visitor at birth.
I think that's more of a support person. Before they were mothers alone by themselves with no father, significant other, etc.
Right.
Right. So now they can have one.
Right.
It can be the father or someone else, but just one. And I think a lot of our hospitals are doing the same thing here in Oklahoma.
Yes, yes. No, thank you for sharing that, Barbara. That's a good point. And trying to put this together, and as everybody said, this came out this weekend, and this came out, 2 days ago. So I think the Governor Cuomo's executive order was also over the weekend, so we didn't, get that bit changed. But other questions or comments from anyone?
We do have a question in the chat box.
Okay.
And it says, how would speakers, the panel here, recommend approaching people approaching their facilities to change policies to support babies being breastfed?
Let's see. Dr. Webb, do you want to tackle that one?
I don't know if we're talking about initiation or the issues with separation or what. I think, again, it's just go back to science. There's nothing that says that breast milk is transmitted. If we look at most viruses, flu, respiratory viruses, I'm speaking of respiratory viruses, and Dr. Drevitz may say that too, that's usually not in breast milk. It's more the droplets in your hands and, being close to your baby. But if you're holding your baby, if you're bottle feeding your baby, you're going to be close to your baby. So I really like the World Health Organization statement that talks about kangaroo care, holding your baby, using good respiratory hygiene, hand washing if you're doing kangaroo care or holding your baby. And I think if you can talk about that, then that helps kind of keep breastfeeding together.
And I would add on too that I think they can certainly cite the CDC guidelines that they just updated over the weekend, for the general public, so that mothers know that the CDC does recommend direct breastfeeding and keeping mom and baby together, and it's her decision. So unless she's too sick, but it looks like Dr. Arnold's ready to jump on that. Go ahead.
Well, I think the other thing I would say is that when I've had conversations with patients that they weren't agreeing with my recommendations, I think it's always really helpful to start with asking your doctor, like, what are you worried about and what do you think the chances of that are? Because that way you can really understand kind of what your doctor's worried about. We're not malicious, right? We are probably being super conservative. And I think we would all admit that, To me, the worst case is like, oh my God, what if somebody dies because I was like too liberal and not worried enough? And so I think that's the thing that we're all worried about. Sometimes when I tell a patient, like, hey, I'm recommending this because the risk is 5% or whatever, and I hate that 5%, and they're like, no, 5%, no problem, I'm not doing that. So I think if you can really just start the conversation with, okay, well, why are you recommending that? What are you worried about? What do you think the chances are? And then it really lets you guys have a good conversation so that everybody understands the decision that's made.
Okay, we do have a couple more questions here. Let me scroll back up one. Okay, sorry for that. I have here, and I think I actually missed one, so I'll get back to the other one. This one says, can Dr. Arnold or Dr. Webb speak to the breast hygiene we should recommend to mothers?
That was a big discussion among the breastfeeding listserv that I'm on this week, and really soap and water, and Dr. Drevitz can speak to this too, but just cleaning with soap and water is, that gets rid of the virus fairly well. I think some people were trying to recommend alcohol.
Oh, no.
Really some pretty draconian measures. And I think everybody kind of finally came to the consensus is just soap and water.
I would agree.
I agree. Soap and water would be just fine.
Okay, so this one kind of tacks on to one that we've already asked. So it's challenging when AAP and ACOG, other organizations, have conflicting recommendations. So where someone is asking how to approach facilities to support breastfeeding. To add to that, this question says, who decides for a hospital's practices?
I'll speak to my hospital. We've been, and I know most everybody has an incident command or a group that's probably looking at every single area and how can they breast protect or surge, or how can they get ready for this. So every day that group combs through the volumes of data, just like we did for this presentation. They try to make the best decisions that they can. You know, we have spoken out when they've decided something. We've spoken out and said, hey, you know, really, this is also, if you look at the data from other countries that have done this, or if you look at World Health Organization, CDC, everybody else is a little different than AAP. We think for this, for our group and for our hospital, this might work better, and just take those things into consideration and try to adapt it to your hospital. But going to those up the chain of command has been very beneficial for us, and they've listened to us because we know our areas the best. So that's how we've done it, is kind of grassroots, I guess.
And I can speak to that a little bit too from, well, I'm not directly working in the hospital anymore, but I've been in communication and preparing for this webinar with some of the OU Medical Center and some of our OUHSC physicians. And as even when I worked there, at least for women's services and NICU, I mean, they have an interdisciplinary leadership group that's going to oversee a lot of the care practices happening, and especially when there's a crisis like this and they're coming up with something new, it's going to be interdisciplinary with nursing leadership and physician leadership, and you know, all of the physicians who may have some care role in that area, family medicine, peds, OB, and then even bringing in you know, infectious disease, depending on what the issue is. So certainly that's you know, what they were doing in this case as well. So.
You know, that's a very interesting question, and this pandemic has highlighted issues from national bodies that differ. For example, early on in this pandemic, WHO was downplaying the seriousness of it, stating there was no person-to-person transmission based on what the Chinese government had said at the time. Of course, they changed that and reversed that opinion some time later. WHO was also slow to institute a global health hazard and then call it a pandemic. In the United States, we've also seen the US CDC, you might say, have difficulties with their recommendations and their testing. And so those of us at the university and who have been involved in preparedness have really been spending a lot of our time sourcing information and trying to look at the primary data as best as we can, and then trying to make our own decisions based on the best available evidence. For example, in one of the groups that I'm working with, we've used a lot of the European CDC recommendations just because they seem to be more timely, and as best as we could determine, they fit the data that as we could interpret it better. But it is very difficult when you have discord at the national level, and so it just means that you have to trust your local folks and trust that they are really searching the literature, the science, and really trying to bring forth the best recommendations possible, which is what I think we're doing here at OU.
And I can add on to that too. Thank you for that, Dr. Drevitz. I represent the Human Milk Banking Association at the U.S. Breastfeeding Committee. So they are actually working now to pull together kind of an excuse me, infant and young child feeding and emergencies group with representatives from a lot of the USBC members, but also from other kinds of emergency response type and preparedness groups, so that we can learn from this pandemic and maybe avoid some of these challenges with future pandemics, and maybe have a more a more concerted response together, and not all this conflict and discrepancies. So, anyone else? Sarah, any other questions that you're seeing come up?
Yes, well, we have another one here asking if we know of any of the effects or possible effects of the prescription medications given to moms suspected of or diagnosed with COVID.
So there are, first of all, there are no FDA approved treatments for COVID-19. There are only investigational treatments and treatments of drugs that are used for other diseases and conditions that are being repurposed for COVID-19. So I don't know of any data about some of the new antivirals like remdesivir that is being used. And I would suggest that that's probably not useful in pregnancy or breastfeeding, but that would have to be searched, and it's not even approved for anything yet, so it's considered investigational. The drugs that have acquired the most press are hydroxychloroquine and chloroquine. Chloroquine is an anti-malarial that's been around for decades. Hydroxychloroquine is chemically similar and can be used for malaria, but is also used for autoimmune diseases. And then an antibiotic is azithromycin. So my understanding of breastfeeding is azithromycin is more than likely safe in breastfeeding, and also probably in pregnancy. I would have to look up the answers for hydroxychloroquine, which goes by the trade name of Plaquenil. I think most of the obstetricians and pediatricians would know that off the top of their head. But my recollection is that they are safe in pregnancy. And you're only using these drugs for a short time, meaning a few days, as opposed to hydroxychloroquine is used often for years in autoimmune diseases, and chloroquine for months to years in prevention of malaria. So it's just short time exposure, but it's always best to look. Those drugs can also cause some cardiac problems called long QT syndrome. So at OU, we are only using those for hospitalized patients, and we're monitoring their heart tracings or EKGs very carefully, as well as looking for other side effects.
That's a great question, and we've got good resources that we can double check, and we can always send that information out, what we find when we send the link for the recording and slides and so forth too. So
we do use Plaquenil in pregnancy, and it's safe. We use it for like lupus and things like that, and it is safe during pregnancy.
And LactMed, who we'll put a plug in for, says it's also safe. Usually because you're right, you're not going to use it for a long term.
Right. So we have a quick follow-up, and then one more, well, maybe two more questions here. A follow-up is to the one about just the basic hygiene care, where you guys all kind of said soap and water, but the follow-up to that was specifically, is that for every feeding that you do your hygiene? Like if you give the basic?
Yes. Yes. Because again, the thought would be that every time you might have sneezed or coughed or something in between there. So I think that's the general recommendation.
yeah, and this we're talking COVID positive mom, a known positive. So this is not like every mom has to do this every feeding. So.
Okay, and thank you for that clarification. I think that's kind of what people are needing. What's for a regular mom? What's for a COVID mom? And sorry to say regular if that was inappropriate. Our next question, it's a little bit long, so I'm just going to read it as they typed it. Due to unique challenges of care for pregnant women past 23 weeks when fetus is viable, is it being advised that COVID positive pregnant women be transferred from community hospital to tertiary care center where maternal fetal medicine and NICU are available, specifically if mom is bad enough to be hospitalized or when she presents in labor?
You're muted.
Okay, sorry. This is Kate Arnold. I work at a clinic right now. I have been reading the hospital protocols. For right now, there was kind of this debate about if you move all the, and Dr. Drevitz, you can help too, but there was kind of this debate at the beginning in thinking about pregnant moms is, should you move all the pregnant moms to a place where they stay healthy, or should you move all the sick people to a place where they're away from the pregnant moms? And the reality that's been coming up recently is, like you said, a lot of pregnant moms are going to be COVID positive. So ideally what we're looking at is wanting these moms in hospitals where you do have ICU capabilities if they're deteriorating clinically. Now, I don't know what the exact qualifications are going to be for transfer, but I would want them in a place where they had access to an ICU and ventilators. Dr. Drevitz, anything else you would say?
I think that's what I would say. You know, it's obviously COVID would cause a viral pneumonia in somebody, and that would be the problem. And my guess is from the literature, most young women and pregnant women are going to do just fine, and many may not even know they're infected. So it's not mandatory, but if somebody, say, has a high-risk pregnancy or underlying medical conditions, for example, heart defect or asthma, that could cause a problem with COVID, and they have respiratory problems, at that point you would want them in some place that would have a high enough level of care that they could have intensive care units and ventilatory support if needed.
What about diabetes? Because aren't we seeing a lot of patients having, more severe symptoms if they had diabetes? So we're going to have gestational diabetics.
So diabetes is found in a relatively high percentage of adults who are hospitalized with COVID. What's not clear is if that percentage is actually higher than the background incidence of diabetes in the community. So my guess is that poorly controlled diabetes is going to be a problem. Well-controlled diabetes may not be such of a problem. The conditions in adults that are sort of coming to the forefront tend to be cardiovascular issues. So mainly hypertension seems to be what is most common and most severe.
The other thing I would say is that when we look at pregnancy risk for diabetes outside of, like, people who were diabetic before pregnancy versus diabetes that is just during pregnancy, most of the women who have gestational diabetes diagnosed at like that 24 to 28 week screen don't have those vascular complications because their disease is not long-standing. It's just due to the load of the pregnancy. And so generally gestational diabetics, I would not expect them to do poorly during COVID. It would be, like Dr. Drevitz said, the long-term elevated hemoglobin A1Cs.
All right, other questions, Sarah?
There was one, and I can't remember if we've done that. Have we discussed specifically what OU is doing? Someone wanted to know, what is OU doing with their practices?
I don't know if
regarding breastfeeding.
Right. Do we have anybody from OU that's on right now? I had gotten a copy of their, at least their interim protocol a week or so ago, but then of course things have been changing day to day. And what they were doing initially was if mom was a PUI, patient under investigation, or COVID positive, and that they were discussing the risk and benefits with the mother. of should they consider separating and isolating the baby. So kind of somewhat following CDC, but certainly also mom has the option to decline separation. And then if the baby is separated, of course, then it's going to go to the isolation room and PPE for everybody. But they do have pasteurized donor milk available if mom is not able to provide to bridge that gap until she's building her milk supply. But that was a week ago, so some things have changed since then. So they said they were constantly reevaluating that, and that was coming from some of the pediatricians and neonatologists that would be dealing with those babies.
Okay, I believe that's all of our questions that have been typed in, but those who are still listening in, if you would like to unmute yourself to ask a question, you are more than welcome to do so.
Or any other challenges or comments people are facing, anything that we didn't cover that we need to look into.
Where would the slides be available from this talk you all for this?
Yes, we can get the slides up today. And then Sarah, how long do you think the recording will take?
I can have the recording up by tomorrow morning. The slides I can definitely put up by the end, just in the next couple of hours.
Yeah.
And I will have those on our resources page on our OBRC website, which should have been connected to most of the invites and everything, but OBRC for Oklahoma Breastfeeding Resource Center at OUHSC.
That's our email. So, and we have a COVID-19 kind of section. So we'll make sure they're posted there where all the other COVID-19 information is as well. So.
Are there any?
We did have another question. Someone is curious if we are testing moms on admission, if that's like been a blanket thing that we know of across Oklahoma.
I would say no. I don't know, Dr. Arnold. Yeah, I see.
I have heard a couple hospitals are moving towards that. I haven't heard of any that have actually implemented it yet.
And I know OU was not doing that, at least. Yeah, the end of last year.
Integris is actively discussing that possibility, but nobody's implemented it yet that I know of.
Okay.
This is Dr. Webb. I think the testing has been so limited until this week, we didn't have those options.
Good point. Good point. So Sarah, see any other questions in the chat box or anyone else that wants to unmute and ask a question? We have a few more minutes.
I have one question.
Kate Cobus, raise your hand. Yeah, go for it.
Just like a question about like storage and transporting milk. Like if the mom is positive and she's separated, how are we transporting that milk from her room to the baby's room? And then like storage guidelines for her milk in the refrigerator with other mom's milk.
If you want to check on our website, once again, where we have our COVID resources, we have a couple of sample kind of policies from other hospitals that have already addressed that and looked at, but some are talking about kind of the gist of it is, of course, hand hygiene, and mom's got a dedicated pump, or she's hand expressing whatever, and then whatever container she's expressing milk into, that's going to get wiped down and handed over to the staff, who everybody's in PPE now anyway, and then putting that inside a plastic bag for transport to wherever the baby is. That's kind of a quick summary of it, and probably storing that separately. I mean, you store all the mom's milk in her own container in the freezer in the NICU anyway. So, but that's a good, that little detail I'm not 100% sure on. As far as does that need, I wouldn't say it needs to be a separate freezer, but probably certainly its own container, box or whatever in the freezer. So anyone else? Kate, did you have anything else? Did that help?
Yeah.
All right. Anybody else?
Actually, we do have one. I'm just curious because I know we are creating, OBRC is trying to create a prenatal education, but we did have a question of virtual classes for moms, for pregnant moms. So do we know of any virtual prenatal classes that anybody could recommend?
Jacqueline. Jacqueline's the one that's been calling everybody around the state. And she's updating that about weekly. So that list of all the lactation resources, including classes or support groups, is posted on our website. But Jacqueline, do you happen to remember if anybody was doing any virtual?
Most places are not doing anything. It sounds awful, but because they did have in-person classes. But yes, that is not on that resource guide because there really wasn't anything to report. A few places did like the Milk Bar. They still did like a Facebook Live. I know that depending on the facility, like I know Duncan regionally prenatal ed because of the way that they do it. It's kind of like during a prenatal visit. So of course the mothers still have to come in for prenatal visits. But that's why we will have that virtual prenatal ed that we've designed that'll be on our website next week for all moms, physicians, whatever. It's available to whoever needs breastfeeding prenatal education.
That's right. Yeah, I remember now you mentioned about Duncan Regional. And so they were actually trying to get that prenatal ed to the mom when she comes in for her glucose screen, which they have to still come for that in person anyway. So, but did you have a sense, was that kind of in any kind of small group setting? Of course, everybody's maintaining social distancing, or they're just trying to give that one-on-one?
I think it might be one-on-one because they're still doing it. And this was what, Friday? So what's today? Wednesday?
Right.
Yeah. So I do assume that it is probably, or, you know, if however they're keeping patients in a waiting room or whatnot, and if the instructors on the other side of the room, you know, whatever the case may be. She did say, the lactation consultant there said that they were still doing that. Of course, they're smaller.
Right.
You know, they may be able to finagle that to still meet the social distancing standards.
So we did have one of our former hotliners, I believe. I just see Paula, so I'm assuming. But she says that La Leche League has virtual meetings on Fridays from 8 to 10. I do not know if that is La Leche League Oklahoma. So Paula, if you could. And then Ruth had also mentioned Oklahoma La Leche League's Facebook having some type of meeting, but that might have just been a support group. So sounds like La Leche League is trying to do some stuff, and that could be where people could check things out.
Well, we can definitely follow up on those possible options and make sure we have that added to our COVID-19 section as well. So, so that's great to know that. Yes.
This is Alexis Burtz. I may be able to provide some more information on both of those things.
Yeah, go ahead.
So the Leche League of Oklahoma is partnered with the Leche League of Kansas, and Kansas is doing a large virtual online meeting every Friday. As mentioned, you can find the link shared on both the Leche League of Kansas and the Leche League of Oklahoma website.
Oh, great.
As far as online prenatal breastfeeding education, OSDH sent out an email this week that all of their prenatal education that's normally handed out in their WIC offices is now available online at breastmilkcounts.com. So physicians or care providers can direct mothers to that website to get all of the same information that they would normally be receiving in person. And I'm looking at the website now. It's very user-friendly and broken into multiple sections for postpartum and working moms as well. So that would probably be a great thing to share.
Okay.
At Variety Care, we have a grant that we've been able to continue with. It's aimed at moms who are earlier in their pregnancy. It's called Healthy Expectations. And it tries to do education around breastfeeding, nutrition, as well as mental well-being. So we have a therapist who meets with them. And so we've been able to continue all of that support through telehealth visits. So that's aimed for moms who are earlier in their pregnancy, but we do have kind of that wraparound support for moms who are interested.
Okay. And we do have Renisha has a question. Renisha, are you still available where you can ask?
Yeah, I just didn't know how to chat to the whole group, but I was just trying to share a virtual breastfeeding class that was being offered for this Saturday. And she had it for the first 16 registrants. They could access it for free, but I included the link to the host because I can't figure out how to share it with the whole group here. It's just giving me like options to share with the host. So I just shared it with like the host and one of the co-hosts. Maybe you guys can share that with everyone else.
Oh yeah, absolutely. No, we'll make sure we try to, yeah, kind of collect all of this information and provide that once again when we send out slides and so forth.
Did you see the link that I sent?
Sarah, can you see?
Actually, Renisha, if you can try to send again, I have changed the chat box where everything can be made public. We had to keep it private just because there's some people playing bad tricks. So if you put it in the chat box now, everyone should see it.
Sure. Okay. Thank you. That's all. Thanks.
Great.
I have a question.
Whoops. Yes.
Go for it.
Yes, I was wondering about the availability of WIC breast pumps at this time, especially for NICU moms who may be wanting to have access to a Symphony pump at home.
This is Amanda Morgan. I can try to answer that a little bit. I work as the breastfeeding education coordinator for WIC, and we are recommending that clinics just be very careful with the issuance of the multi-user pumps. And many states are actually discouraging issuance, but we understand that there's certain situations, moms of multiples or babies in the NICU, in which that would be a necessary tool. And so we're flexible, but we do want to be careful and try not to spread. So likely the people that still have our pumps that we, the multi-user pumps, the pumps that we loan, they will likely get to keep them for a lot longer than initially planned, just out of precautionary measures. So hopefully that answers your question.
But Amanda, as far as the single user pumps that a mom, say a working mom might normally.
Yeah, we're encouraging those to be issued pretty much exclusively. So those are still available. We have plenty, also plenty of manual pumps available.
Great, great.
How do they access those pumps? Are the offices closed?
No, clinic staff are still available. I would recommend calling, but it's going to be different depending on where you are across the state.
And they may have, if some are working from home, because WIC is doing a lot of their work remotely or on the phone, then they may just have to schedule a time to be able to pick that up.
Yeah, actually, clinic staff should be there. There's some people are working from home, but clinics are still open.
Okay, so somebody would still be there.
Becky?
Yes.
This is Emily Berkebile. Can you hear me?
Yes, yes.
I work for Intertribal WIC in Miami, and we're kind of doing the same thing that the young lady just said. We're currently working from home, but I just met a mom yesterday. Her baby's in the NICU, and as crazy as it sounds, I mean, I met her in the parking lot. I had to issue her a Symphony pump, but we both had on a mask. We had on gloves, and that's how we had to do it. We stayed 6 feet apart and kind of handed her the pump. She's using a Symphony pump in the NICU at Freeman anyway. So, she knew how to use it. I gave her the guidelines, that kind of went over precautions on kind of how to be extra protective with the COVID-19 instructions on how to clean it and everything. And then again, I met a mom today and gave her a Medela pump and style, kind of the same precautions. So, even though we're working from home, we're still available to meet those moms to issue those pumps. And we are also doing, you know, the phone calls, but we're also having to do some breastfeeding contacts over FaceTime if we have to. So kind of how we're doing things also. But yes, our moms are still available to get those pumps if they need them.
That's great to know. I appreciate everybody who is helping with that.
Definitely lots of creative processes being explored right now. So I'm just checking our time, and I think unless there's any one final burning question from anybody, I know our speakers have patient care and other commitments to take care of, and we are just a little past our time. So Sarah, any final question in the chat box that we didn't really address? And any questions that come up, people can always email, and we will, you know, try to address those afterwards as well.
There are no more questions in the chat box, just Renisha and Jenilyn providing some information about their virtual classes.
And we can make sure we get that posted or get those links up as well. So so people kind of have a one-stop shopping place for some of that. All right, well, I think we will conclude this webinar, and thank you so much for attending today and all the great questions, and thank you especially to Dr. Drevitz, Dr. Arnold, and Dr. Webb for being willing to take time out of this crazy time right now to share, and everyone stay safe. All right.